Could you give us just a brief background about your experience as an OT and how you found yourself working in this specific area?
Yeah, so OT wise is I learned about occupational therapy when I was in my undergraduate program. I actually applied to get into a PT program because I didn't know about OT.
Okay.
So didn't make it into PT because, not always the best student. And then I applied to an OT program and I didn't get in because they said, hey, you're just sort of bouncing from PT. And I'm like, yeah. so, but I learned more about OT, and when I learned too that it had some focus on research, I think I was hooked by that. But yeah, I started working my first jobs, went to Western Michigan University for the OT program after I graduated from UND in psychology.
Okay.
And so we're close, right? You're Grand Valley?
Yes, yeah. So you're familiar with the area?
A little bit, yeah. I liked where I was in Kalamazoo and Portage and
Okay.
spent a lot of time around there. But yeah, it was a good program. And then I did brain injury was really what I wanted to get into. So I practiced brain injury for quite a while, outpatient typically, and some group milieu brain injury. Then I started doing traveling therapy. So did lots of stuff, inpatient rehab, nursing home, etc. And then settled down in Montana for a while and did long-term care, continuity, kind of continuing care, dementia care, assisted living, kind of independent living, OT work. And I just really loved that. And then decided I needed to go back to school. So I got my PhD I left in 2002 to go get my PhD from USC. And I got that and finished that in 2007. Because I'd read stuff that USC was doing. And I'm like, okay, this rocks. And how can I do this and put it in my practice? And I felt like I really needed to go back for a degree. And I'm glad I did. So after I finished that, I was the program director at Idaho State for a few, like 4 years, and then got my position where I'm at now at Colorado State University. So my practice early really never involved sleep at all. I would just say I was, traditional occupational therapist. I did traveling for a while. Usually older adults is what I did then at the end,
Okay.
and really loved it. The sleep thing came about because at Colorado State University, I was doing research for a veterans program, a supported education program for military veterans at CSU. So we've been doing some really good research on that, and we found that sleep problems were really a big deal for the veterans, especially those with PTSD. And got a grant from Wounded Warrior Project, and that's really what launched us. So that was like 5 years ago or so.
Yeah,
So yeah, go ahead.
we noticed that you had done some research with the REST program, and we saw an article that you had published. And I guess we just wanted to know a little bit more about the REST program and how it all started, how many
Sure.
participants you have, and their diagnoses, if they have any.
Yeah, and what I think I'll do too, I just submitted another article to AJOT,
Okay.
and I'll go ahead and send that to you guys. It's under review now, but they're gonna like it. I'm not I'm not too worried about it. But Christina, I think I'll send that article to you.
Okay.
But so you can have it. Okay, so what is REST? Yeah, so we got the grant, and then I realized, oh, now I got to make it happen. So, which included a sleep intervention called cognitive behavioral therapy for insomnia. So the REST program is really that. The intervention itself is called multi-component cognitive behavioral therapy for insomnia. And as of like 2016 or 2017, it's really become now, should be the first line of treatment for chronic or primary insomnia. So medications really are not recommended anymore, maybe as an adjunct, but the behavioral interventions, because of the evidence supporting their efficacy, really are the first line treatment for approach for sleep problems. So what kind of sleep problems did they have? Yeah, they were having problems. They met the classification for what's called primary or chronic insomnia, which means you have trouble falling asleep, staying asleep, or you wake earlier than you want, 30 minutes or more in those things. You have daytime complaints that you associate with the poor sleep. So it might be, fatigue or difficulty concentrating, mood. and that these difficulties have been persisting for 3 months or more. And once you hit those criteria, it's chronic or primary insomnia, and it's really exists because it's a behavioral problem, and sort of getting your body out of sync with its natural body clock and engaging in activities I think you think are going to help you sleep better, like taking naps, or when you go to bed early so you can really get all the sleep in. But if you're not sleeping in bed, it's really not being effective for you.
Okay.
So then we received training. So Natalie Roll is the occupational therapist that delivered the one-on-one sessions during the clinical trials that we ran, and I would lead the group session. So we ran what I called a thick, rich, creamy soup intervention. So it included each week the participant got 1 week of group or 1 hour of group, and they got 1 hour of one-on-one intervention. And to do this intervention, you have to complete a sleep diary. So every day the veteran completes a diary about when they went to bed, when they woke up, if they woke up in the middle of the night. So we know about the quality of their sleep and what happened during their sleep. And then we use that information to then adjust their sleep prescription. And this is part of CBTI. The first thing, the main components of CBTI, the things that are really the drivers that make this thing work, is what's called sleep restriction therapy, where you limit their time in bed to the time they can generate sleep. They're actually able to create sleep already. Stimulus control is by associating bed with sleep. So an example might be up on your phone in bed or watching TV in bed. We nix all that stuff. It's just bed and sleep, and that's it. And if you're having difficulty sleeping at night, you don't try harder, you have to get out of bed. As well as some sleep hygiene related indicators. So we're always concerned with noise and sound and light in the room, temperature in the room. We're concerned with caffeine use or alcohol use a little bit, but those are really minor issues in the big picture. And then we also employed some mindfulness strategies. So we engaged them every week in the intervention to a little bit of different aspects of mindful practices. So they got some yoga, they got some seated breath work, they did some mindful walking as well, because part of the difficulties in falling asleep are also associated with the arousal. So one thing that's really critical, I hope you guys have a sense of as well, is that part of our program really was educating the folks about their sleep systems. And I think that's something that occupational therapists really need to get in touch with, is really the science of sleep and understanding how and why people sleep. So we cover a lot of what's called the two-process model of sleep, which includes the sleep driver system and the circadian system. And we also cover models of insomnia, so they understand and can understand why the insomnia is existing. And when we recommend things for them to do, like get to bed the same time every night if you can, but definitely wake up at the same time every day. Even if you're tired, doesn't matter, get up. You're still sleepy, get up and set that body clock. And so we really educate them about how their sleep systems work. And then by the time we're done with this intervention, our intervention was 7 weeks long, which is, average for this kind of thing. It can be a little bit shorter too. They had the tools, and they literally said that we have the tools now. We need to sleep better. So, and before I move on, the sleep problems exist or started perhaps in part because they have a precipitating event. So what causes the sleep problems to occur in the population we've been working with, which is military veterans? Oftentimes it's basic training. I swear, up their sleep. They begin to get into really poor habits about sleep, like taking naps. Well, that's effective in the military to be operational, but it's really not effective consistently when you're back at home. And so they probably had a precipitating event which caused their sleep difficulties, engaged in certain behaviors to try to get better sleep that actually are counterintuitive and don't help sleep. Now, did they have other comorbid conditions? Yeah. So we had folks with post-traumatic stress disorder. We have folks with depression, stress, and anxiety for mental health challenges. Pain was often on board as well for these individuals. So they're already dealing with this. Plus, mild traumatic brain injury is common in this population, and a number of them had mild traumatic brain injury. So we probably also have some cognitive overlay on top of these other challenges. But CBTI is really a robust intervention or a robust treatment. So we evaluate to make sure that we're not going to cause any harm, but we work with people with PTSD or with obstructive sleep apnea or with depression, as long as we're delivering the program safely. And we have been consistently doing that. So no adverse events in our delivery of the treatment. I'll be quiet. I said a lot.
No, thank you. You answered a lot of our questions. One of the other questions we had is, you mentioned that they participate in group and individual therapy. So do you see one as being more beneficial than the other, or do you think the combined approach is more relevant?
Yeah, so the gold standard delivery in cognitive behavioral therapy is a one-on-one intervention only. But that's just how they've done it. I think why we decided to do, and I'll say I think both together are probably more beneficial, and part of the rationale is they get to be with other veterans and establish some sense of camaraderie, which was common to them, and to share in challenges that they all have. It's not unlikely that someone is waking up in the middle of the night because of nightmares, and someone else might also have at least experienced that as well, and know that, you know, it's not uncommon that they don't want to go to bed because they don't want to wake up from a nightmare. So I think the group really helped to reinforce the challenges that they face. And also, when you in this program, we're asking people with sleep restriction, if their bedtime typically has been 10 o'clock, but they get into bed at 10 and they can't sleep till midnight, they're just tossing and turning, they're on their phone. When we do sleep restriction, they don't go to bed at 10 anymore, they go to bed at midnight. So they have to stay up until midnight and find things to do. And that's night after night after night now, this new bedtime. And so other people can, in the group process, can help give ideas about what they've done with their time to try to stay up until their, what we call their prescribed time to bed. And sometimes it's just so that one person can, the other people go, suck it up, dude. You know, it's like, just do it. And when people do adhere to the intervention, it's really powerful. It's really effective. So, you know, one concern might have been, well, that's maybe too much time for people, but our attrition rates in our treatment, so keep this in mind, for the treatment to work, you have to adhere, you have to follow the protocols, the client does, and that they need to stay in the program until they've seen good benefit. And we see attrition rates at about 12%, meaning, you know, 1 out of 8 people might drop. And that's compared to the VA system, which many of their practitioners have been trained in CBTI. The problem is, and why we developed the intervention, is because there's not enough providers to help meet the needs of these persons with sleep difficulties. But the veteran programs, their attrition rates are closer to 24%. You know, almost like, you know, 1 in 4 are dropping out of their program. So we really felt like, because we think the care they received was part of why they stayed in our program. So I think both are probably better, but you can deliver it one-on-one, just one-on-one. You can actually deliver it in the group setting too. And like I said, ours is a thick, rich cream soup.
And how are you finding the participants? Are they somehow referred to you, or they find out about it online, or?
Yeah, for the REST project itself, you know, I was part of doing research on a supported education program at CSU called New Start. So supported ed for veterans that have service-connected injuries. So we got quite a few of our folks from that, but we also then were in touch with the other veteran-related services on our campus to just get the word out to veterans. And I also had an ongoing survey process on campus, and so anyone that took the survey, their landing page when they were done was, hey, you know, do you have problems falling asleep or staying asleep? Are you a veteran? You know, come to our program. So it was pretty easy for us to recruit. And prevalence rates, so this might be important for you guys too. Excuse me, I say guys with all love, and I was working on that. So hey, so what am I saying? Oh, so in the population of sleep problems, especially chronic insomnia, is about 10% of the prevalence rate. Right? So 1 in every 10 people probably have a sleeping problem. When you go to veterans, the conservative numbers, military veterans are about 20 to 40% have a sleep problem. And then when you look at the veteran that has a diagnosis of post-traumatic stress disorder, their sleep problems are about 90%. So we knew we had a pretty healthy number of, a large number of veterans on our campus. And if you just put those prevalence rates on, let's say, 1,000 veterans, well, that means 200 to 400 probably have a sleep problem. So, and we were fine, and it was pretty easy for us to recruit the people we needed.
And with the participants being students, how do you think that a lack of sleep influences their participation in other occupations in their life? Do they report
I'm
that?
gonna reflect that right back to you. How do you think it does?
Well, I think it would negatively impact it. So any participation in education would be decreased probably if they're not getting enough sleep. Maybe social participation, they're not as motivated to participate in that.
Yeah. Yeah, so poor sleep, lack of sleep, or sleep debt is consistently associated with decreases in cognitive functioning, decreases in psychomotor functioning, decreases in ability to regulate mood. Decreases in problem solving. So if you kind of apply that to the academic environment, yeah, they probably are at a disadvantage because of their sleep problems. And they likely do impact school performance. So in our studies that we've done, we did assess what are considered typical parameters for sleep. So we looked at the sleep parameters themselves, like how much total sleep they're getting before and after the program, their sleep efficiency, which is an aspect of sleep. We also looked at mental health indicators. So what was real cool from our program is, they got better sleep. So they went from maybe one standard deviation above normal sleep problems to one standard deviation, or to the standard, or to the mean or below normal sleep problems. So their sleep problems substantially improved. We saw reductions in anxiety, depression, and stress, and we're not treating those. We're just helping them sleep better. But because they have to organize their day and their time and their routines at night and their routines in the morning to help them fall asleep and stay asleep, we really feel like they're getting control over their sleep that they never had before. So that's positively impacting their mental health. Plus, they're organizing their days to get the things they need to get done completed as well. And because they're sleeping better, the psychomotor issues, the mood issues, the attention issues were resolving as well. And we would get comments that's like, yeah, my head felt clear for the first time, and I don't know how long. And we also looked at participation related indicators, but we did see some trends in social role performance improving, but wasn't statistically significant in one study. But we saw consistently that perceptions of their activities as being meaningful were improved after the end of the treatment, meaning they're able to obtain experiences of meaning out of their day-to-day activities they weren't able to experience before. So increased levels of pleasure in their activity, senses of connectedness with other people, feeling a sense of competence and control over what they do. So we do see some impact on sort of day-to-day performance or daily occupation as well, which is rare because most studies on sleep really aren't looking at that right now, kind of in the sleep world.
Out of the ways that you assess the participants, do you have like a preferred method? I know that you probably use objective measures, but do you also use subjective measures like observing their sleep pattern?
Yeah, so how do we assess? Let's go on the sleep side specifically. The main tool we use to classify them to see if they could be enrolled in the study was the Insomnia Severity Index. And just so you know, Natalie and I are putting in a workshop for AOTA, so hopefully we'll get that accepted and you guys should come.
Yeah.
The Insomnia Severity Index at a score of 10 or higher means moderate insomnia. So that was the screen tool to go, hey, they probably have a sleep problem. But that doesn't tell you whether or not they have primary insomnia or chronic insomnia. The primary or chronic insomnia is a diagnosis in the DSM-5 and within the sleep diagnostic manuals that truly is what CBTI is designed for, cognitive behavioral therapy for insomnia. And when you do report this, don't report it that it's CBT, because it's not CBT, it is CBTI.
Okay.
That insomnia piece is critical because they learn so much about their sleep systems as part of this intervention that it's really unique compared to the more standard CBTs you might find with, say, depression treatment. Once that being said, what other assessments do we use for sleep? The biggest thing that you have to do, and if you're going to treat someone with a sleep problem, the best thing you can do is give them a sleep diary and help them understand how to fill out a sleep diary, and then let them do that for about a week and meet with them again. And their eyes are open in terms of, boy, when am I really going into bed, and how long is it taking me to fall asleep? And so we document that, and we cannot and will not deliver our treatment, the CBTI treatment, unless they are completing a daily sleep diary. And if you're interested in that, there's one called the Consensus Sleep Diary, and you could look that up and Google that if you want to get into that. The Consensus Sleep Diary is just a bunch of sleep researchers really got together because everyone had their own version of a sleep diary to create maybe a shared version that they could all be fairly satisfied with. So I would say if any of the tools that are critical for this, it'd be, say, an ISI to establish some level of insomnia, and a sleep diary as well to get the variables you need and really help the person understand their sleep. There's bunches more assessments, but I think that's a good start.
Yeah, definitely. So you are also reviewing the sleep diaries. It's not purely for the participants.
Oh yeah, we have to.
Okay.
Yeah, because from the sleep diaries, what you generate is you get variables about their time to bed and time out of bed. So we can and time asleep while they're in bed. So we can generate like sleep efficiency, which is a critical factor in our sleep intervention. If their sleep efficiency is low, which it typically is right away, they oftentimes are spending like 10 hours in bed and maybe getting 7 hours of sleep. Serious. So that's really low sleep efficiency. And when their sleep efficiency is low, that helps us know that they're not getting good sleep. And we don't know that unless we have the sleep diary. And we need the sleep diary to help know what time are they going to bed and getting up. As I mentioned before, we educate them about this 2-process model of sleep, including the circadian system and the sleep driver system. So you see this probably in sleep hygiene, or you hear people say, well, get up at the same time every day. And it's critical for us so that the participants know, well, why am I getting up at the same time every day? Just because this chick's telling me to do it? Just because that jerk is telling me to do it? And then we educate them, no, it's actually because your circadian system sets and is entrained by the activities that you do every day. And when you get up at the same time every day and expose yourself to light, you're exposing your circadian system to entrain it to become more regular, which makes falling asleep and staying asleep easier. So it's really critical that they have some awareness of that. And we can't give them that awareness unless they complete that sleep diary.
Very interesting. Olivia, did you want to ask some questions as well?
Yeah, so do you feel like you work with many other OTs with sleep specifically, or other disciplines that should be involved with sleep?
Yeah, so that's a good question. And I'll tell you from the context of this intervention, in working with veterans specifically. So that being said, we would want to be in touch with their primary care provider, because we are in this intervention. Officially, we are treating a clinical diagnosis, that you can identify in the DSM-5 called primary insomnia. And so it's not uncommon that folks might be on meds that they're using to treat some of their sleep disturbances. Like they might be on a med prazosin for nightmares. They might be on some type of SSRI or some type of, a medication for depression or anxiety. We aren't trying to take or change those meds when we do this intervention, but because we're affecting sleep and we have a diagnosis of sleep, we reach out to their primary care physician. So that's one for sure that we would want to link up with. So they're aware of what we're doing. And it's really what most often would happen, I think, all the time. They go, yeah, that sounds great, go for it, go ahead and treat. So that's good. Other ones that maybe we would intervene with, at least when we were doing our intervention, was maybe folks, because they had VA services and they would be connecting with the VA, they oftentimes would get a polysomnography study. So we might have some interactions with, like say, the pulmonologist who runs the polysomnography studies. That's like a sleep study. And we also might intervene with a respiratory therapist, because probably 20 or so at least % of them, and I think prevalence is a little higher in general, but might have obstructive sleep apnea, so they've got a CPAP. So I had one guy that I worked with. I was doing group N one-on-one with him, and went to the VA with him when he was getting fitted for his CPAP and getting a CPAP reviewed. So that's some of the folks that we oftentimes are exposed to would be their physicians, maybe the primary care or the pulmonologist who did the sleep study, because they're very commonly involved in that, as well as a respiratory therapist. There could be others, but those are some of the more common ones.
Okay. In addition to veterans, since you work predominantly with them, in our research, we found that sleep interventions would be really effective for older adults and children with autism specifically. Do you feel like other populations within the community would benefit from sleep therapy outside of those two?
Yeah, so here's an article I'm going through right now. It's a chapter. We're putting together a grant right now to use CBTI for adults with autism. It probably could work with children with autism as well, but this particular call is for adults, and that's our sample that we work with. So we'll probably have quite a few folks that are in college going to school that are on the spectrum, maybe have overlay of ADHD that's going with too. Is it perfect? Yeah, I think for autism, it's a great match. If you think about some of the concerns that children and adults with autism have, they have sensory, potentially over responsivity, and so that it might be harder for them to fall asleep at night. They have higher levels oftentimes of some anxiety, and so that also could make it more difficult to fall asleep. They have epileptic waveform disorders that are common when you look at sleep studies and EEGs of the brain at night. So it's possible that during the night they are having, these micro awakenings that are occurring, and it's maybe possible that by having a more efficient sleep, some of that could be reduced. Like I said, we saw decreases in mental health challenges after people were sleeping better, the veterans were. There's other things in autism too that I think would, where it's not uncommon that these individuals are up, playing video games or on their electronic devices and doing it in bed. So they're also probably engaging in what one might call sleep hygiene or inappropriate or ineffective sleep hygiene behaviors that also can limit the effectiveness of one's sleep. So autism for sure would be great. Older adults, I don't want to get into all the details there, but yeah, they think about limited activity routines, and you need activity during the day to build up your sleep drive, which is one part of the two-process model of sleep. So older adults definitely could help, or we could help older adults understand their sleep systems, understand their day-to-day behaviors and routines, and then modify those routines to promote healthy sleep and monitor that. So I think OT is really in a great position to be delivering interventions to improve sleep. I just feel like we as a profession need greater education on sleep and the sleep systems and sleep challenges, maybe in different populations, and then how we can positively impact sleep and give them some tools. So that's really one thing that I've been trying to work on a little bit is, one, understand it for myself, but two, disseminate this information to the profession so we could help grow the profession's understanding.
Do you use a lot of the suggestions and interventions that you suggest to your veterans for yourself? Like, do you find yourself doing a lot of the things that the strategies that you impose?
Yes and no. So, because like we'd say, hey, don't take naps. And we say don't take naps because it's slow, even though someone's sleepy during the day, and a nap was, hey, I need to feel awake again. If you do take a nap, it depletes what's called sleep drive or sleep pressure, meaning when you get to the evening, now you're less likely to fall asleep easily at the time you want it to, just because of that nap during the day, sort of taking away some of this what's called sleep pressure. And I could get into the neurochemical aspects of that, but I think beyond that, now, should I not take a nap? Well, I shouldn't take a nap. It's probably not going to be effective, but I don't have insomnia. And I love naps. So I'm going to take a nap. Just because I might not do what I tell other people to do is partly because I don't have insomnia, so it doesn't bug me that much. But that being said, when I came back I was in Japan over spring break, and I knew I would be in quarantine for 2 days. I set up my room with my TV and a PlayStation 4, and be able to watch movies in my bed, and had my food in my bed, and had my laptop in my bed. I did everything you should not do to have good sleep. And I had sleep. I had irregular wake cycles, I was going to bed at a different time, or not till 3 a.m, waking up at a different time. But I did it in part because I know how sleep works, and I wanted to try it out. And I totally messed up my sleep. But then with my kids' help, we moved everything back out of my room, and I set it up, and now I just sleep in there. And that's really, that's what we say for them. It's like the only thing that you should be doing in bed is sleep and sex, because we're not going to tell people you can't have sex in bed if you want. So sleep and sex in bed, and limit your bedroom to sleep. And it's a behavioral issue. It's Pavlovian in a sense, where there's this unconscious association between being awake and being in bed, and we try to remove that. So do I engage in some of those activities? I do. Is that the best thing to do? Probably not. But I don't have insomnia. But it's definitely for these individuals that do have insomnia. And when we learn that these are the factors that are extending and sort of maintaining their problem with insomnia, then definitely they should be taking these things and adding them to their lives, like getting up at the same time every day, getting out of bed if you can't sleep, not doing things in bed other than sleep, staying active and engaged during the day, don't take naps. And we have this nice list of what we call the tools. It's their toolkit. And that when they're done with our program, they take these tools with them, because they're going to have relapses. Problems are going to happen. Stress is going to happen. There's going to be a few nights, oftentimes, where people can't sleep. Insomnia in and of itself is actually a good thing. It helps us be awake when bad. But we just don't want it to persist. And when it persists and it's chronic, then it's a problem. And really, OTs can do a lot to help.
There's been a lot of apps developed, and with smartphones and everything, there's always the track sleeping apps, and iPhones do it now, and Fitbits do it now. What's your take on that technology and the use of it?
I think it can be overall positive. We found a couple of things though, like we were using these Fitbit Flexes when we were doing our intervention. The one thing we found is that people were really over-focused on their Fitbit. They're like, oh my God, and they're looking at it, checking it all the time. And almost like it added some level of arousal, or when I mean arousal, like worry and concern about their sleep. They're like too focused on it almost. But I think overall it's the other thing we found is that when we compared the Fitbit, when it indicated that someone was asleep or awake versus when people did their sleep diaries, there was great disagreement, almost an hour differences on average for time asleep. And you can't run CBTI with a difference like that. You need within windows of 15-minute errors, and these errors were huge, like an hour. Maybe those are probably improved with some of the Fitbits and readers now that can monitor your heart rate, I think, and as well. So the tracking monitors, they can be good to help enhance your awareness, I think, overall. And the apps that are out there, like there's Sleep Shut-Eye, if you've ever heard of Shut-Eye, or Sleepio. The VA has what's called CBTI Coach. And those actually can be really effective when you're entering your own sleep and wake times, and can be effective in improving sleep if you have chronic or primary insomnia. There's good evidence to support them. So I think apps can be really effective and used well. And within our intervention, we would use a book by Manber and Kearney. Or it's Kearney and Manber, anyway. But it was like how to sleep, with stress, depression, and anxiety. And that book is a self-help book, really about cognitive behavioral therapy for insomnia. And giving folks education and awareness about sleep, why they're not sleeping well, and what tools they can use to sleep better. So even self-help books that are smart can be, and really approach and understanding of sleep are important. I comment on that because I think some people go, well, I'm going to do meditation, or I'm going to do yoga, and I always sleep better, so yoga is the best treatment, or meditation is the best treatment. Well, they're going to help because they help to decrease arousal in the arousal system, makes it more challenging to fall asleep or stay asleep. So if you can calm the parasympathetic nervous system, yeah, that's definitely probably going to help in an individual sleeping better. But I think OTs really need to understand why and how our sleep systems work before we get into helping people sleep better, you know? Like if you're gonna have someone fill out a sleep hygiene index, see the ones that are challenging, and then say, now you need to change this, this, and this. Not only does the OT need to know why they should be changing these aspects of their day-to-day life, but the person who's they're asking to change them needs to know why they need to be changing these as well. You know, you empower your client with knowledge and information as best you can. That being said, you know, if it's a challenge when you have someone who is maybe a kid with autism, then you definitely are working with the parents too. But yeah, autism will definitely have some other challenges, especially if you have like developmental delay on top of the autism spectrum challenges. So there's a lot of research still that needs to be done to determine, you know, what type of interventions that are behavioral can be effective for these folks with autism. Like autism, for example, melatonin is known to be actually not as effectively developed within individuals with autism, and they're not sure why. There's a challenge of the serotonin changing into melatonin, and there's not enough melatonin. So there's a circadian system dysregulation within persons with autism. Children, for sure. It's not well studied in adults yet. So there's so much we don't know.
Because there's such limited research on sleep and OT, how do you go about finding evidence-based interventions, or what would be your suggestions for implementing that with patients if it wasn't just veterans? Like, if we were to go out and work with people in
yeah
OT?
how do we know what we need to know, right? And how can we as a profession get there? So have you guys seen a book by Green and Brown? Do you know of such book? The authors' names are Green, Brown, and OT and Sleep. Let me oh, it's not Andy. Andrew Green and Carrie. Andrew Green is in the UK. Carrie Brown is in Canada. They co-edited a book called An Occupational Therapist's Guide to Sleep and Sleep Problems. Have you guys seen that book?
No,
I've not.
So it's been out since 2015, I think. And when I teach some of my courses now, I weave sleep into them that it wasn't woven in before, and I use this book. Same with Natalie when she teaches to like an adult disabilities course in our OT program. We went from like maybe a few slides in a lecture to like 3 hours, right? So we're at least at CSU, we're really trying to pump up that information. So I would definitely say look there. That's some good information. I'd also say that there's a website that you should go to too if you want to learn a little bit more. It's called sleepot.org. Sleepot.org is an international network of occupational therapists that are really trying to expand the profession's understanding. And it's an international network, which is really pretty cool. So you can see who some of those members of that network are. I'm one of those. And Natalie is one who I work with as well, and people from around the country. So we're, in a sense, educating ourselves to know more about this. How else could we make it change? Well, I think the profession, and this would include AOTA and probably ACODE, who's the accrediting body for our education programs, would want to change the standards, the ACODE accrediting standards, so that there's more content on sleep in our curriculum. I think the challenge could be occupational therapists are going to make a claim, which we can in Colorado. So for example, the OT Practice Act in the state of Colorado specifically includes sleep as one of the areas of occupation or activities of daily living that is within the scope of practice of occupational therapy. Not every state has included sleep explicitly, and I think some of them get away with just ADLs, right? And we'll say, well, sleep's an ADL or sleep's an occupation. I think you can kind of get away with it, but I think we truly need to have more of that information in our accrediting, in our standards, at least one standard that's talking about, sleep. Right now, it's more general about occupation in general. So I'd say that would be important to increase the standards so that all academic programs have to address sleep and sleep problems. And then other than that, you got to get out and you got to educate yourself. And there's not a lot in occupational therapy. If you want, you could come to we're putting our CBTI for OT program online. So that will be available for occupational therapists to take, it's kind of a self-paced online course for a few months. And then we've been delivering a cognitive behavioral therapy for insomnia course for OTs in the last couple summers, but unfortunately we had to cancel this summer because of, that COVID-19. So, yeah. So I think you got to get out there and read. When Natalie and I prepared ourselves to deliver this intervention, we went from zero, almost nada about sleep to getting advanced, basic and advanced training in cognitive behavioral therapy for insomnia, reading our off, reading books, reading articles, and then we had peer consultations as we're delivering the intervention. We met every week on our clients so that we could peer consult with each other about what we think is the right thing to do based on what we've learned. And we always had a sleep specialist as a consultant. His name is Don Posner. He's at Stanford University. He's a psychologist, and our training was under him. And he's a champion of other professions that can really effectively deliver the intervention, should be delivering this CBTI for intervention. And he liked us because we were rocking it. And when we had more challenging cases, we'd check in with Don to make sure that we were doing no harm.
Well, you've provided us with some really, really good information, and we don't want to take up too much more of your time this morning. But just one last question, just as future OTs, is there anything else that you'd like us to take away regarding the importance of sleep and its impact in general?
So this is going to be something that we'll be presenting at the, we hope to present at AOTA at a workshop, is that I think OT should at least be screening for sleep and have an understanding of that they can identify whether or not a sleep problem occurs or exists, and then determine, is there something they can do to help? So I think that's the limitation in our profession. One, I think OTs, they probably know that sleep's important, but they don't know what to do about it. So they need the tools to know, to assess its presence, to determine whether or not it's a problem. And then the OT needs to prepare themselves with continuing education, because you're not going to get it in your basic education, in your master's program or your entry-level doctoral program. You need to do your own self-study and go to conferences and learn about sleep, read about sleep, and join the network of OTs and reach out like you guys are reaching out to people who are doing this practice. And you got to just take the bull by the horns and do it.